So I'm Prithviraj Bose. I'm a faculty member in the Department of Leukemia at MD Anderson. I co-lead the section of myeloproliferative neoplasms. Today I spoke, at this meeting I spoke on optimizing the selection of currently available JAK inhibitors for the treatment of myelofibrosis. And as our audience may know, all the approved agents today for MF in the US or anywhere are JAK inhibitors. And there's 4 approved in the US, ruxolitinib, fedratinib, pacritinib and momelotinib. So my task was to sort of guide folks through how to select them, when to use which, and sequencing, and things like that. What are the factors that determine those choices? So there are not clear criteria, but I think what one has to appreciate is that these are different drugs. They are all JAK inhibitors, yes, but some have other targets, some do certain things better than others. For example, ruxolitinib is great for spleen and symptoms, momelotinib is probably the best for anemia, pacritinib has some anemia benefit, but then also has the advantage of not lowering blood count so that you can use it in patients with very low platelets, for example. So they all have their little, nuances and little differences. Now the FDA approvals are all line agnostic, so there is no stipulation of line of therapy as far as the approvals are concerned. So some of the bigger takeaways that I would mention, again, as you can imagine, this can get very nuanced and very extremely sort of in depth if one wants to get into it. But some of the big things I'll say is that ruxolitinib has a survival advantage that's been clearly demonstrated. The others do not have that, and that may just be that their trials were affected by a clinical hold, or the comparator was not placebo. So absolutely it might be a class effect and not just unique to ruxolitinib, but the fact is that it is only shown with ruxolitinib. So that is that. And then as far as improving anemia, I think momelotinib is the best agent we have in that regard. I think fedratinib has a place. It doesn't have much of an advantage over ruxolitinib in the front line, but in the second line, if the blood counts are preserved and the spleen needs to shrink or symptoms need to be improved, I think fedratinib is a very good drug. Pacritinib, like I said earlier, for platelets less than 50 is usually the way to go. That's the safest drug in that setting. It has good efficacy in that setting, and that's a difficult group of patients to treat. And momelotinib, perhaps is the drug that fits in a lot of places. It's got this anemia benefit, but it also improves spleen and symptoms substantially. So it could be used in frontline or later lines, but again, the choice sort of depends on how severe the anemia is and what's the biggest need of the patient. And again, like I said, one has to balance that with the fact that with ruxolitinib we have this survival benefit. So it's a lot of different things to consider. It is by no means straightforward, but those are just some highlights.